It is rare that a patient will tell you exactly where their pathology is, but that is actually what they are doing when they tell you they have a cranial nerve palsy. You just have to know where to look. A video about the 6 syndromes of the 6th cranial nerve. To understand the 6 syndromes, you have to know the anatomy of the 6th nerve. It starts in the brainstem at the facial colliculus, what looks like the butt of the brainstem, like a cute little baby butt jutting out into the 4th ventricle. It then travels anteriorly through the brainstem to exit out the ventral surface of the pons. It exits the brainstem at the inferior aspect of the pons, under what looks like the potbelly of the pons, what I call the dad bod of the pons, and then travels anteriorly in the subarachnoid space towards the clivus. It then enters Dorello Canal, a canal that I think sounds more like a canal in Venice than an anatomic structure. This canal is at the lateral aspect of the posterior clivus, right by the petrous bone. The canal then travels superiorly, taking the nerve up with it towards the orbit, where the 6th nerve needs to go to innervate the lateral rectus muscle. The exit of Dorello Canal is marked by the petrocleidomal ligament, which, as its name implies, runs between the petrous ridge and clinoid. The 6th nerve actually runs under this ligament, which holds it down against the medial petrous ridge like a seatbelt. It then enters the cavernous sinus, where cranial nerves 3, 4, and 5, as well as the internal carotid artery and sympathetics also run. Now, the 6th nerve is located more medially than the other nerves. In fact, it is the only nerve to run in the cavernous sinus itself, rather than in the wall. It then enters the orbit through the superior orbital fissure. Here, it is joined by cranial nerves 3 and 5, with 2 in pretty close proximity. As soon as it enters the orbit, almost immediately it makes a lateral turn and innervates the lateral rectus muscle. Here's a recap of the course of the 6th nerve. Remember it, because where the pathology is along the course of the nerve will determine which syndrome we will see. So remember, it starts at the big butt, exits out the potbelly, goes along the Venetian canal, underneath the seatbelt, through the cavernous sinus, and enters into the orbit. At each point of the course of the nerve, injury to the nerve will cause a different syndrome, giving us the 6 syndromes of the 6th cranial nerve. The syndrome we get depends on the location of the lesion. Here are the syndromes laid out against the region of the cranial nerve course that they are associated with. Now, in the brainstem, there are many important structures in close proximity to the 6th nerve nucleus and its course through the brainstem before it exits. Notably, the pyramidal tracts containing your motor fibers are in direct proximity with the interaxial 6th nerve. Now, compressive, ischemic, or inflammatory lesions may affect cranial nerve 6 here, but they would likely affect the other cranial nerves that are in close proximity as well as the pyramids. Now, there are specific syndromes, but the key point here is that a brainstem lesion will cause deficits in other cranial nerves, and more importantly, it will cause a deficit that may have motor weakness, a unique deficit to the brainstem. And that means it's time to call neurology. As it travels through the subarachnoid space and into Dorello Canal, the nerve is susceptible to changes in intracranial pressure. Because cranial nerve 6 is uniquely tethered in Dorello Canal, when the brainstem moves up or down with changes in pressure, the nerve gets stretched. Therefore, changes in intracranial pressure can uniquely give you bilateral isolated cranial nerve 6 palsies. After it exits Dorello Canal, it travels under the petrocleidomal ligament. Here it is susceptible to infections of the petrous apex from complicated otitis media. Now, this region would rarely give you an isolated palsy because there are other nerves in close proximity. So, If they have a complex sixth nerve palsy with hearing symptoms, think of this region. After it enters the cavernous sinus, things start to get complicated. Because of all the nerves in close proximity, isolated palsies here are rare. Cavernous sinus syndrome is deficits of 2 or more of these structures. Now, both the deficits and differentials are extensive. It's time to call neurology again. The cranial nerve 6 then enters the orbit. It has a very short orbital course. Remember, it immediately takes a lateral turn after the superior orbital fissure to innervate the lateral rectus muscle. Therefore, not much of the nerve is separated from cranial nerves 5, 3, and 2 in the orbit. And because it is mainly in close proximity to these nerves, lesions here will cause a superior orbital fissure syndrome or an orbital apex syndrome, not an isolated palsy. Now, the last syndrome actually isn't anatomic. It's a cranial nerve 6 palsy with no other identifiable cause. It's kind of like the transverse myelitis of cranial nerve 6. It usually is going to be microvascular, microinfarction, or post-inflammatory, post-viral. But you must rule out the other 5 syndromes before calling this syndrome. So, now you know the 6 syndromes of the 6 cranial nerves. Now go impress a neurologist. If you like this video, you can like it or subscribe to see more. Also, you can follow me on Twitter and Instagram at TeachPlayGrub. Because what is more to life than learning, living, and eating? Thanks so much.